So you basically got penalized from Medicare because you guys were more efficient. Is that what you were saying?
We didn't get in the bundle. So, when BPCI A came out, they do a historic run, and all the conveners, kind of organize this. And there's a bunch of different conveners that would run these models. And I forget the exact number, but let me say ballpark, our practices average total cost of care. So they take in, SNF utilization, physical therapy utilization, which are the big post-acute numbers that drive that up. And they create a historic number. And then your bundle, which you get thrown into then, is based on that and with a goal to decrease it. So we were something around like 19,000, I think, from a historic model. Maybe it's a little bit less than that. The hospital that is down in Athens, Ohio, which one of our partners works at, we don't do really cases there anymore. Their bundle price was going to come in at $28,000, for the same surgeries. So we hadn't really nowhere to move down, and there was a number of other reasons why we didn't jump into it, because they didn't cover partial knees. We typically do knees 6 weeks apart if we're doing both, and you have 2 knees under a bundle. But ultimately, our room for error for improvement to making it financially meaningful, with all the headaches that would go along with it, and then also waiting a year and a half to get paid on the upside, was just not there. So it was kind of incentivizing really low efficiency places to get enrolled and just try to make a little bit better. And those that were already efficient, there was no bonus of, hey, you guys are doing a great job, let's just pay you more because you are doing a good job.
That's interesting. How some people for being inefficient can actually be rewarded for it. That's kind of how a government system works sometimes, huh?
Well, when I was in the military, we were judged by our OR utilization, which was the amount of time that the patients were in the operating room. So if I want to be the most efficient or most productive surgeon, I would bring a patient in the operating room at 7 a.m. and I wouldn't leave until 3 p.m. And I would do one case and I would have 100% utilization. That would be the best metric of anyone in the system. Whereas if I knocked out 3 total joints and was done by noon or 11, you underutilized your row. So it's very backward metrics by which the government sometimes evaluates things.
Right. So were there surgeons that took advantage of that, and they would stay in surgery 6 hours to meet
No,
those
I don't think
numbers?
intentionally. I mean, there's some folks that
Right.
weren't very efficient, but I mean, then it gets to some other incentive models, and I got paid the same when I was doing 6 cases a day, and someone else was doing 1. I would see about 30 patients in the office, and I had a partner that would see 5. And
you got paid the same.
Got paid the same. And the staff was there from 7 to whatever it was, regardless. If you started running late, anesthesia would just cut your OR time. So that case is canceled because we're not going over this time frame. People were just clocking in, clocking out. And again, there was very good people, and they're just incentives weren't aligned to behave any differently.
So that's why in a surgery center, at a free market like your surgery center, when you're competing with bundled pricing and employers that are looking for less expensive options, you can't get away with stuff like that.
No,